Welcome to St. Louis on the Air. One thing we all have in common is that we all sleep. The commonality ends there because we have different sleep patterns and needs. Sleep or lack of it can affect everything from our productivity to our safety to our personalities and to our health. I'm Don Marsh. That's our subject today, sleep. We're hearing from three experts in the field. Dr. Joseph Ogile is the founder and CEO of the Clayton Sleep Institute. He is also the medical director of sleep services at St. Anthony Medical Center and associate professor of medicine at St. Louis University's Department of Internal Medicine. Dr. Walter Lemon is a neurologist at Barnes Jewish Hospital. Joining us by phone from Chicago is Dr. Stephen Sheldon, director of the Sleep Medicine Center at Children's Memorial Hospital and professor of pediatrics at Northwestern University. Gentlemen, thank you so much for being with us.
Thank you.
An interesting subject. I'm sure that I and our audience is going to learn a lot today. But Dr. Ogile, let me begin with you. Are we all the same with regard to our sleep and sleep needs?
We're not all the same. What we need, the amount of sleep we need, is biologically predetermined when we are conceived. And over time, each of us has some biological changes with age. And I know Dr. Sheldon will comment on that in the young children, but over time we change how we sleep. But the amount of sleep that we need, each of us, is somewhat different. The peak of the curve is about 7.5 hours, but the amount in any individual patient is basically predetermined. We frequently try to alter that ourselves by either using natural things like caffeine or depriving ourselves of sleep to work more. But at the end of the day, if we don't get the right amount of biological sleep that we need, we're going to suffer some consequence.
Dr. Lemon, how well can we control our sleep?
Well, to a degree, with medication and with behavioral changes, there is some degree of control that can be exercised. But I would agree with Joe that you can't stray too far off the reservation.
And Dr. Sheldon, let me put this one to you. What are the consequences of too little sleep?
Well, the consequences can be multiple, from inability to perform during the day, inability to function at school. If one is too sleepy during the day, it can result in automobile accidents and major hazardous behavior.
Is it possible to sleep too much, Dr. Ogile?
There actually is some suggestion that people who sleep both too little and too long may have higher mortality. So in one regard, one might contend that too much sleep could be an issue. The reality is, in our society, we rarely have that as an issue. What we do frequently see in the office are people who come in, and it's not frequent meaning a few times per year, but people that have very high sleep needs and are what they call long sleepers, who need more than 10 hours biologically. If you think about when you were getting grades in college, and Don, you were always, if you think about the bell-shaped curve, and then the middle is about 7 hours and 45 minutes. That's the peak of the bell. That's where all the C's were. And of course, you were already on the left where all the A's were. Those are the short sleepers. And then on the other side are the long sleepers. So we will see them. They need more sleep.
I think I was a long sleeper. I think that's the way it worked out. Dr. Lemon, what about napping? Is that a good thing, and does it have any real benefit or not?
Well, I think you hear frequently about the power nap, and I think that in most normal individuals that isn't necessary. I think when there is deranged sleep for a variety of reasons, people find themselves needing to take a nap during the day, but usually that's not something that is required.
I had heard once that some of the great people of our time were nappers. Many of them were. Churchill, Kennedy, people like that.
Well, I think those were people who were trying to beat the curve, as Joe said, diminish their long stretches of sleep and make up for it with 45-minute periods of sleep. The Seinfeld episode where Kramer has decided to go that way is a perfect example. It works for some people, didn't work for him.
Does it? Yeah, I was about to ask if it does rejuvenate in any sense.
Well, some of this is also biologically determined. napping in a person who has been sleep deprived, and the most industrialized societies, people are considerably sleep deprived. Napping is quite helpful, but there is a circadian biology that shows that there is an afternoon dip in alertness and performance, and many cultures pay attention to this afternoon dip, and they include a siesta in their day. They function well with a short nap in the afternoon, and this is what is biologically determined.
But it's not necessarily something that we would want to recommend for everyone.
Well, it's culturally based.
Yeah. Go ahead, Dr.
Well, part of it is the siesta issue is right on target, because before the advent of light, people slept in a different way. Their sleep tended to be a little bit more broken up at times. There's some interesting work on that. They did a study in Spain several years ago because they still had the siesta. They still have it built into their day. The unfortunate thing is that with suburbanization, what the study revealed was that people were still getting the time off, but not taking the siesta. So their society is becoming more and more sleep deprived, and people are sleeping on trains in their doctor's offices and so forth because they're actually taking that nap that they should have for their total amount of 24-hour sleep and using it to shop or do other things.
I think while we're on this subject of quantity of sleep, from a neurologic perspective, there are a couple of interesting features. One is looking at the total quantity, what I call the final exam or all-nighter effect. Again, as Joe referred, that was never an issue for you, I'm certain, but you see students who will leave a paper at the end of the semester to do at the last minute, or, as I said, a final exam because they weren't going to class, and a goodly number of consultations in a neurologist's office occur after such individuals have a generalized seizure, a convulsion. Now, that's rare in the total group of people, but it's dramatic, and the neurologist would need to find whether that needs further evaluation or treatment. I think the other thing, two things that are worth mentioning, is migraine headache. Sleep deprivation is clearly a trigger for migraine. And lastly, individuals that attempt to do long-haul driving, I think it's prohibited for truck drivers, but you try to go from St. Louis to New York in one sitting, these individuals will start to have hallucinations and potentially suddenly go to sleep.
Well, the people have also had hallucinations and difficulties taking various medications. I can think of some politicians that come to mind that have had some difficulty with, I think Ambien is one of the things that's the problem. Did you want to comment on that, Dr. Sheldon?
Sleeplessness is definitely a problem, and the more you are awake, the more sleepy you become. So there are studies that have been done at Harvard by Dr. Robert Stickel that quite clearly show that the all-nighter really doesn't work, and that people that sleep better actually score better on exams and perform better educationally.
Dr. Ojal, what about this this notion of medication, and that I mentioned some of them can be as bad as the problem, it would appear?
The medicines certainly cut both ways. We don't take the approach that we're either for or against medications. We want to use them just like you would use a power tool when you build a cabinet. We want to use them in the right and most appropriate ways. Some medicines do have side effects that could have carryover. For instance, things like Ambien or really any of those, that class of drug, we call those BZRAs or benzodiazepine receptor agonists. They're the old drugs like Valium. It's not Valium, but it's the way that drug worked. These newer drugs capture that activity without many of the side effects. Unfortunately, occasionally you can get some abnormal behavior with those, or they can lag over where they make you sleepy in the morning or the next day. The things that are talked about that you're alluding to are like people who get up and eat at night or have abnormal behaviors that are reported frequently. Those will occur with most of these medications in a few patients, so we need to be alert to that. At the end of the day, all these tools we should be using to improve daytime function. That's really our goal of sleep. Sometimes we mistake the goal. If their sleep, if they perceive it not to be perfect, but their daytime function superb, that's really our life goal. So sometimes we have to just reassure folks that they don't need medicine for that.
Could you be more specific with regard to the daytime function? I'm not quite sure I understand what you mean by that.
So what we mean by daytime function is when you're up during the day, during your normal day period, now, assuming you're not a night shift worker, so let's take that off the table, then those folks, if they tell you their sense of vitality, their ability to function during the day without large doses of caffeine or other stimulant wakefulness promoting medication, if they can do their work or interact with their family in a vibrant way, not falling asleep, not sleepy, their daytime functions is quite good by any measurable means. Therefore, their sleep, one would infer in a backward fashion, that they must be getting adequate sleep given all things being equal. So sometimes people focus on, quote, how they're sleeping, when in reality we want to manage their sleep to improve their daytime wakefulness. That's our goal.
It's kind of a chicken and egg kind of thing, isn't it?
Yes, sir.
Right?
Well, I think that the most important factor here is making an appropriate diagnosis and treating for that particular diagnosis rather than treating a symptom. Just as you wouldn't want to treat a fever just with shotgun therapy and without being quite specific for what you're treating. Making an accurate diagnosis is most important in treating either sleeplessness or increased sleepiness, daytime performance, and nighttime activity. So the key is finding why someone is either sleeping too much or not sleeping enough, and then focusing the treatment on that particular disorder rather than a particular symptom.
Before we leave the medication issue, I think it's important for the listeners to understand, and I agree wholeheartedly with what Stephen has said, but in terms of communicating with their physician and making certain that the physician gets the signal, it's important to distinguish between difficulties getting to sleep and difficulties staying asleep. Because once a decision is made that a serious underlying condition isn't present and the person has enough distress in a consistent way, the medication approaches are in fact quite different.
I have to take a break, but let me, excuse me just a second, Dr. Sheldon, I have to take a break, but very quickly, can you tell me what percentage of our population has sleep problems? Do we have any idea?
Depending on what you look at, if you look at the Sleep in America polls, 40 to 50% or greater on any individual issue. For instance, insomnia around 10-11%, obstructive sleep apnea, depending on what age you're in, anywhere from 5 to 15% or greater. Those are the easiest numbers, Stephen, unless you have extra ones to throw in.
No, I think that's fairly accurate. We conducted a study a number of years ago that looked at complaints, and if you ask the right questions, you can find about 70% of patients that present will have at least one sleep-related complaint at some point in time.
All right, let's take that break now, and we'll come back and continue our conversation on sleep. And we have three experts on the subject, two of whom are in studio with me. Dr. Joseph Ogile is founder and CEO of the Clayton Sleep Institute. Dr. Walter Lemon is a neurologist at Barnes Jewish Hospital, and joining us by phone from Chicago is Dr. Stephen Sheldon, director of the Sleep Medicine Center at Children's Memorial Hospital in Chicago.